Dr. Carolyn Taylor, thank you so much for joining us. I'm Virginia, one of the organizers of the group MS My Way, and this is meant to be our monthly meeting. We plan to have you come and talk with us, but due to the popular abundance of caution right now with coronavirus, we've opted to not gather this month for the meeting. And so we're doing this video conference with you so that you can share your presentation with us. Thank you.
Yeah, thank you, Virginia, and thank you for having me. I've been looking forward to this,
Yay.
and I'm just sorry that we can't be there because it's really so much more fun to be interactive and talk to everybody and take questions. But we'll do our best. I think I'm the one that brought this up because I have an MS patient that just flew back from Japan. She was at a big convention there, and I saw her last week, and she gave me a big hug, and then contacted me this weekend to tell me that she's sick. So I'm fine, but I just don't want to put anybody in harm's way, just in case. So when we talked recently, a few people mentioned that they were really interested in hearing about what's new in MS. And I think too many of these talks center around disease-modifying drugs, which are not always appropriate for every patient at every stage of disease. And I'm going to highlight that a little bit. But I just want to talk about some of the other things that were brought out in the ECTRIMS meeting in September of 2019. That's the European research meeting on MS. So I'm going to start by talking about the goal in the future of personalized medicine. So with over 17 disease-modifying therapies right now, our goal should be to diagnose patients earlier and initiate treatment as soon as possible, but with the appropriate agent. Pharmaceuticals have come a very long way since 1993 when we first got beta-seron on lottery, and we didn't know then if we should be treating patients or waiting till they got worse because we didn't really know what the side effects of the drugs were. But we've come such a very long way. But we also know that pharmaceuticals are not the only thing that help patients with MS. There are positive impact on lifestyle changes such as diet and exercise. And because of all these things, there's help for patients at every stage of their disease. Okay, so we're talking about the goal of personalized medicine today because we have so many disease-modifying drugs to choose from. So one of the big debates that we have that has to do with personalized medicine, next slide.
Yes.
Is should we start treatment with high versus low efficacy drugs? Historically, we have always started treatment with the low efficacy drugs, the injectables, and then as patients got worse, we would move on to a more higher efficacy drug. But that may not be the right thing to do. Insurance, however, still dictates how we choose our drugs to some extent, preferring that we start with the low efficacy drugs. But in the future, we may be able to determine who might benefit from high efficacy versus low efficacy treatment early on. And we might be able to do that with neurofilament light chains. Neurofilament light chains are structural proteins from nerve cells that can actually be measured in the bloodstream. And they are a marker of central nervous system damage. They discovered these years ago when they took blood samples from people in the military as they were entering the military, and they banked the blood samples. And then later on, they followed up on these patients, and they looked at the blood samples from patients that went on to develop MS compared to controls that did not have MS. And they found that the MS patients had evidence of these proteins, which we now are calling neurofilament light chains. And we know that they're a marker of central nervous system damage. So they might be useful in the future when we diagnose a patient in determining which patients have a greater risk of a more aggressive course of MS, or later on we may be able to determine whether or not a patient is likely to go into progressive disease.
Okay.
Because they have these neurofilament light chains. So we once thought that high-dose vitamin D was more helpful in patients with MS because we discovered that vitamin D acts more like a hormone in addition to a vitamin. The vitamin gets calcium into our bones. So we once thought that we wanted our patients with MS to have high levels of vitamin D. Normal vitamin D range is between 30 and 100 in the bloodstream. So we wanted them to be up around 70 or 80 or even 90. But we now know that high-dose vitamin D can actually worsen experimental central nervous system autoimmune disease by raising the T cell excitatory calcium. So the new recommendation is that we maintain adequate vitamin D levels in moderate range, and that is felt to be more beneficial to our MS patients. So the recommended amount of vitamin D is 3,000 international units instead of higher doses. Can exercise help MS? The studies have shown that exercise can delay diagnosis, protect brain volume, slow relapses, and may actually provide short-term improvement in depression, fatigue, balance, and walking ability. Exercise also helps promote fitness, which helps to reduce cardiovascular risk factors. And in that sense, it helps patients with MS because any other problems such as cardiovascular disease layered on top of MS will certainly make MS worse. So I would like to say that exercise should be considered a medicine that we should prescribe for patients with MS at the very beginning of their diagnosis. And like all medicines, the dose and type of exercise needs to be custom fit to fit their lifestyle and their abilities. But it's extremely important. Cigarettes and cannabis. Now, we've long known that smoking cigarettes is deleterious to people with MS, possibly because it increases inflammation. And to be honest, most of my MS patients don't smoke.
As my little personal, tobacco is a nightshade, and I can't eat any nightshades.
Right.
And if I do smoke a cigarette, I kind of notice the same kind of inflammation that I might get if I eat like too much salsa.
Right. And it does cause inflammation. So we advise all of our patients not to smoke. And there's 2 studies presented at the ECTRIMS conference that show that these behaviors make symptoms worse, both smoking and cannabis use.
Cannabis also.
Cannabis has been promoted for help with MS spasticity and pain, and you have to weigh the risks and benefits of smoking for those things. Because when we look at patients who smoke cannabis at least 4 times a week, which we consider heavy use, and have cognitive complaints, they did a study where they took patients with cognitive complaints with MS who are heavy cannabis users, and they had them continue to smoke for 4 nights a week for an entire month. And they took another group of heavy cannabis users with cognitive complaints, and they had them stop cannabis use completely for just 28 days. In those 28 days, 1 short month, they were able to determine that the patients that stopped smoking had significant improvement in their memory and other cognitive functions.
Oh, that's huge.
So that is huge. So it affects your cognition, not in an irreversible way, but a reversible way. But it also has a negative effect on your coordination. So it depends on what your symptoms are, really, and how often you use it. And there's heavy smokers and light smokers, but you have to weigh the risks and benefits. Now, another hot topic that people have been talking about for a long time is what's happening in studies on gut bacteria.
Yeah, that's very exciting.
Yeah. So studies have shown previously that the gut microbiome in patients with and without MS definitely differs. But deciphering the best mix of gut bacteria in MS is still going on. We still don't know how to advise people about this and what to do to manipulate it. So there is wide variation in gut bacteria between people in different cities, between different individuals, and there is some similarity in gut bacteria in people that share a same household. So there's still hope that probiotic choices in the future may help calm down disease activity. Next slide is more on the gut microbiome. One particular microbiome that has been looked at is P. histocola. Now, this is a bacterium that has been shown to have both disease protective abilities in an animal model of MS and anti-inflammatory capabilities. The work on this particular bacteria demonstrates that P. histocola can manipulate the systemic immunity and organ-specific disease far away from its action in the gut. So the study with this bacteria in particular has been hugely beneficial in demonstrating that this may be one clue to one way we can treat MS, but we still have to figure out how to use it properly.
Okay.
We have 17 disease-modifying therapies. They are mostly for relapse-remitting disease, early phases of disease. And there is one of disease-modifying therapy that's approved for primary progressive MS, which is ocrelizumab.
Okay.
And that reduces the primary progressive symptom or progression of disease by only about 20 to 28%. It's also an effective drug for relapse-remitting disease. And like all of our drugs, it helps reduce relapses. So again, what do we tell our patients that are in the secondary progressive phase of disease, or our older patients that have gotten all the benefit they can get from these drugs? So if you get to the next slide, it talks about the next frontier, which is myelin repair.
Yeah.
And this centers mostly around a cell in our nervous system called the oligodendrocytes. Now, oligodendrocytes come from a group of cells in the nervous system called glial cells. Glial cells support nerve cells and help them function properly. The oligodendrocytes look after nerve cells by producing myelin, the insulating protective coating that surrounds our nerve fibers. Now, one oligodendrocyte can supply myelin for up to 50 nerve fibers at once. So think of an oligodendrocyte as the center of a wheel with spokes coming out in all directions. So you have 50 spokes coming out from the oligodendrocyte, and each one of those spokes is producing myelin for 50 different nerve fibers. So myelin, as we know, protects the nerve from damage, and it not only protects it from damage, but it makes sure that the message that is traveling through that nerve gets where it needs to go as quickly as possible. Without adequate myelin, transmission slows down, which is why when we're tired or our body heats up, two things that naturally slow transmission on top of myelin damage, we have a recurrence of old symptoms. So the next cell.
Yeah.
So what happens to oligodendrocytes in MS? Well, in MS, the body's own immune system thinks the oligodendrocyte is a foreign substance or an infection. So it builds up an immune attack against these oligodendrocytes. This causes the nerve cell to be exposed to damage, and then the messages can't get through efficiently or may not get there at all. If a single oligodendrocyte is attacked, it could mean that up to 50 nerve fibers lose their myelin. Next slide. So the oligodendrocyte is critical in repair of the myelin when there's been damage. There are cells that we have oligodendrocytes in our nervous system. So we have oligodendrocytes in our central nervous system that are there that are ready to repair myelin. We also have cells called oligodendrocyte precursor cells, or OPCs. And these cells exist in our nervous system, and they migrate to areas of myelin damage and produce new oligodendrocytes when it's necessary to make repair. So two cells, oligodendrocytes and OPCs, are active in all of our nervous systems. So in MS, this repair process does not always work properly, like it does in someone without MS, and we don't really know why exactly. It could be that the cells that produce the oligodendrocytes or the OPCs have to work too hard to repair all the damage, or something else could be going on, like normal aging, that reduces the number of oligodendrocytes and the OPCs from getting there to begin with. And we've known for a long time that there's something about aging alone that reduces our ability to, or somehow reduces our reserve and our ability to repair from MS. And there's a lot of controversy as to what is secondary progressive MS. Is it the aging process where we've lost reserve, or is there some new neurodegenerative process going on at that time?
Mm-hmm.
So, next slide, oligodendrocyte research. Looking at a lot of different agents right now, drugs that already exist, as well as novel agents that may promote oligodendrocyte function and repair of myelin. One of them is bexcarotene, and this is a skin cancer drug. This might be used to promote myelin repair. Studies have shown that this drug targets a specific part of the oligodendrocyte to help the oligodendrocytes produce new myelin more efficiently. Right now, phase 2 clinical trials are underway with this drug. We're also looking intently at the impact of aging and lifestyle, such as diet and exercise, might have on the oligodendrocytes. And as you can imagine, this type of research has tremendous potential for helping the patient with more progressive disease, either secondary progressive or primary progressive. So other treatments right now in clinical trials, MD1003 is biotin, and it is a highly concentrated form of biotin. And we found out that this may activate some enzymes that are involved in cell growth and myelin production. And so it's being used right now in trials for primary and secondary progressive MS. Clemistine fumarate is another drug shown to improve remyelination, and that's a drug that you might know as an antihistamine called Tavist. The dose that they're using in clinical trials is only slightly higher than the dose an individual would take using that as an antihistamine. Simvastatin, a drug that people commonly take to reduce LDL cholesterol levels, is also being tested right now in phase 3 clinical trials. Another treatment that is more widely known is antilingual 1 or opicinumab. Anything with a mAb is a monoclonal antibody, and a monoclonal antibody is a very specifically targeted biologic that attaches to a receptor and activating it. So a protein called lingo-1 occurs only in the central nervous system, and it prevents the development of young cells into oligodendrocytes. Opicinumab, also known as anti-lingo-1, has been found to block the action of lingo-1, allowing cells to mature into oligodendrocytes. This may restore repair of damaged myelin, offering the potential of preventing or possibly reversing disability.
Oh, wow.
I know, that's exciting. And this is an infusion you would get once a month.
Oh, yeah.
Yeah, so there's been 2 clinical trials that have come to fruition. One involved optic nerves, and they showed with antilingual 1 that it enhanced remyelination of the optic nerve and promoted faster transmission. There was another trial looking at delay of disease progression, and that trial did not meet statistical significance. But there's a 3rd trial going on right now where they're combining disease-modifying drugs with antilingual 1. That trial is going to be completed in May of 2022. So that's something to watch out for. Okay, next slide is research into a remyelination switch. So there's a protein that they've discovered called activin A that is important in remyelination. It acts as a switch to turn on remyelination. So the exact receptor that activin A acts upon, or the switch, is called ACVR2A. In tissue from patients with progressive MS, they found that levels of ACVR2A were higher in areas where myelin repair was active, but in MS lesions where there was no myelin repair taking place, the levels were far lower. So researchers are now looking for drugs that can target ACVR2A to promote myelin repair.
Okay.
Next slide. There's another molecular switch that works just the opposite way. PAR1 is a switch found on the surface of oligodendrocytes. Activation of this switch blocks myelin production. Thrombin is a protein in our bloodstream that is produced after we've had some injury, and it travels to the site of injury to assist in healing. However, too much thrombin triggers the PAR1 receptor and blocks myelin production. So researchers have discovered that there is a currently approved FDA drug right now that inhibits the PAR1 receptor and improves the ability to produce myelin in cells treated in a laboratory. And it's not recommended right now for patients to take this drug because it has not been studied yet in animals, and additional research is needed and ongoing. So very exciting information with regard to myelin repair, and that in the next couple of years is where you're going to see most of the new developments.
Yeah, that is very exciting.
It is. So I want to just say, next slide,
Uh-huh.
a few words about stem cell therapies. I get questions about this all the time.
It's a hot topic.
Very hot topic. I just want to reiterate to patients certain precautions when they're looking into these therapies. Unproven stem cell therapies can be unsafe. Some unscrupulous providers offer stem cell products that are both unproven and unapproved. So to do your part to stay safe, you need to make sure that any stem cell treatment you are considering is either FDA approved or being studied under an investigational drug application called an IND, which is a clinical investigation supported and allowed to proceed by the FDA.
Okay.
So right now, the only stem cell therapies that are approved by the FDA are in use in the United States consist of blood-forming cells called hematopoietic progenitor cells, and these are derived from cord blood. These products are approved for limited use for disorders that affect the production of blood. Potential safety concerns for unproven treatments. If people go to Mexico, they go all over for stem cell treatments that promote the fact that they are useful to patients with MS. There can be administration site reactions. The ability of cells to move from the placement site.
I'm sorry, what does an administration site? That means the injection site?
The injection site,
Okay.
yes. So if it's given intravenously, you can have a reaction at that site. That's a minor side effect. But the ability of cells to move, stem cells to move from the site where they're applied to a distant site and change into an inappropriate cell type is a problem. So you could have a stem cell that could go to the wrong place and produce a tumor.
Yikes.
Failure of cells to work as expected, which is another example of that. And of course, the last thing on this slide is the growth of tumors. We haven't exactly figured out how to not only start the stem cell to grow, but how to stop it from growing. There's a lot of messengers in place that direct the activity of these cells. So it's very important that you do your diligence when trying to look at any stem cell therapies, that they are safe. Okay, so I wanted to talk a little bit about complementary alternative therapies that could be harmful for patients with MS.
Okay.
So you get a lot of questions about this because so much is out there and so much is promoted that can stimulate your immune system and therefore help MS. But we don't want to stimulate the immune system in MS.
Right.
Patients with MS have an immune system that's too aggressive in some form. It's not the same as taking a cancer patient or an HIV patient and saying, we want to stimulate your immune system, which isn't functioning properly. So you should, in general, avoid any complementary therapies that promote immune stimulation. And some of them that I can list here for you that I obtained through the Rocky Mountain MS Center, which studies all the complementary therapies and researches them, are alfalfa, arnica, cat's claw. I don't even know how to pronounce this one.
Echinacea.
Echinacea.
Yeah.
Garlic supplements.
Yeah.
Ginseng. Asian and Siberian ginseng. golden seal, grapeseed extract, green
Yeah.
tea, licorice, and saw palmetto.
That's
And in high,
that
go ahead.
that's really interesting to me because a lot of those are very common complementary medicine cold remedies.
Yeah, and the idea of a cold remedy is to stimulate your immune system.
Uh-huh.
But to do that temporarily, like I have a cold and I'm going to take that,
Right.
wouldn't be a problem, but to take that on a regular basis because you're trying to help your MS might be.
Okay, that makes sense. Okay, so if we have a cold, maybe probably just fine to take these cold remedies, but
Correct.
we don't necessarily want to be stimulating our immune system on an ongoing basis.
Correct.
Okay.
Correct. And in high doses, there are certain vitamins that can also stimulate the immune system.
Mm-hmm.
You want to avoid high doses of vitamin A, vitamin C, beta carotene, and zinc.
Okay.
That is the end of
Okay.
the topics that I have. I did want to say a little bit. Someone else wanted to know some information about tremor in MS.
Yeah.
And tremor is present in anywhere from 25 to 48% of patients with MS. Tremor can occur for a variety of reasons. It can occur most often because of cerebellar dysfunction,
Mm-hmm.
type of dysfunction that makes people walk and talk like they're drunk. They can get a very wide-based tremor, but you can get tremors for other reasons. And very little is talked about really with regard to how to treat tremors, because there's so many other things we're concentrating on with MS. But the two most effective treatments are either benzodiazepines, clonazepam in particular, which is a long-acting benzodiazepine. Of course, we have to be careful with that drug because it has addicting potential. And then drugs that stimulate the GABA receptors and calm down the nervous system, such as gabapentin or Lyrica, which are commonly used in MS for other types of nerve pain. They finally had that question.
Yeah.
I wanted to be sure to address that.
Yeah.
Yeah.
Great. Is that the conclusion of your presentation?
It is.
Thank you. That was a wonderful, detailed, and informative presentation. There's a couple of ongoing things that come up in our MS group that we talk about a lot. One of the things that we find is most important for us to talk about with each other is our experience of the cognitive and general neurological impacts that MS has. Talking about MS as a traumatic brain injury. How do you relate to that or work with patients on awareness and understanding of cognitive symptoms that they might be having that they might not know how to identify or realize to identify as an MS symptom?
Well, it's absolutely accurate that it's just like a traumatic brain injury.
Mm-hmm.
Because with traumatic brain injury, you get demyelination.
Uh-huh.
And the symptoms are almost identical, where you feel they have a slowing of information processing speed, and it's almost like someone just gave you ADD.
Yeah.
You have difficulty multitasking, you have more difficulty concentrating on a task. If there's noise around you, you need to do cognitive tasks that are going to require more attention early in the day when you're not fatigued in a quiet room, and you need rest periods. Anything that detracts from your reserves, such as lack of sleep, skipping a meal, pain, stress, that's going to affect you as well. So just living as good a lifestyle as you can, getting your rest, taking your vitamins, getting exercise, and keeping those things in mind, that your intellectual functions are the same.
Yeah.
You can still do the same task, you still can solve the same problems, but you just might be more easily distracted.
Okay.
And you have to take care of those things and just keep in mind that you might have to set your priorities different and set your day differently.
Yeah. Oh, that's
But that's
really
a very,
helpful.
very, very good analogy.
Okay.
I deal with that same questions and problems from both groups of patients.
Both groups? What
Both
do you mean?
groups, traumatic brain injury and patients with MS.
Oh, you do? Oh, okay.
Yeah.
Yeah. Interesting.
And actually, 70% of what's happening in MS is happening in the gray matter, and we can't see the demyelination in the gray matter on our MRI because there isn't as much myelin there. So 70% of what's going on in the nervous system in the brain with MS is actually occurring in the gray matter. And we don't see the demyelination in the gray matter on MRIs like we do in the white matter because it's not as concentrated there. So you can have very few lesions on your MRI and have a lot of cognitive difficulties because of gray matter involvement.
Okay.
So what we're doing now is we're following brain atrophy, looking at volumetric measurements and MRIs year after year, and that's been helpful in guiding us with disease-modifying therapy. So we may not see new lesions, but if the patient is having more difficulty cognitively, and we see that there's definitely more brain atrophy, that might warrant change of therapy.
Yeah. Okay. And I'm sure if we had our full meeting and everybody present, I'm sure everybody would have lots of questions about how all of this applies to their personal treatment plans.
Right.
Yeah. But, because of the abundance of caution and wanting to keep everybody as safe as possible while there's a contagion moving through the world. So my personal treatment plan right now, I just started Gilenya again, and that seems to be something that I tolerate well. And aside from that, my care plan revolves around focusing on making sure that my sleep is as consistent as possible. And the thing that helps me with that the most is hydroxyzine, because I find it to be the safest sleep aid. I also have been taking Adderall during the day to help me with my work and focus. I also smoke weed, and after seeing your presentation, it gives me a whole new reason to think that I should probably just stop smoking weed entirely.
Well, I think you can do it recreationally if you're not smoking it for pain or spasticity,
Yeah.
but on occasion. But I think the person that smokes it regularly, we see these cognitive changes.
Yeah.
And that's a big cause of disability for people with MS is fatigue and cognitive dysfunction.
I also have ADD in the first place.
Yeah, so that just makes it worse, doesn't it?
Yeah. Oh, it's a wonderful combination. As an adult, I'm also really delving into the question and thinking that I'm probably autistic, and that my autism was misdiagnosed as ADD as a kid. And so navigating the difference between what is autism and social anxiety and social difficulties related to autism and what things are symptoms of the traumatic brain injury that is MS.
Right.
For me also, I find that there's only two things that directly, I have symptoms come and go with the flow of stress up and down in my life. But the things that will cause me to have a significant flare-up is significant sleep loss. And I've never had flare-up that wasn't directly caused by a period of intense insomnia. And that insomnia is almost always accompanied with being emotionally triggered in some way, being angry about something, having some interaction with another person that has made me furious. And so I really had to go through a lot of personal emotional work to get control of my emotions. And so so mental health counseling has been one of my number one primary pieces in my MS treatment toolbox of learning emotional self-regulation.
It's very hard, and it's something that helps everybody, but especially patients with MS. Learning to draw boundaries, learning to say no when you know you've done too much, learning to deal with stress effectively so you don't let it affect you and take it all in, learning how to just de-stress, and whether it's medication or exercise or counseling, it's critical because stress affects our immune system our lack of sleep, which goes along with stress. That's when all the repair in the nervous system happens, when we're sleeping. And we all need at least 7 hours of sleep at night to function normally during the day, especially with diminished reserve. So the MS patient, the traumatic brain injury patient, the patient over 60, our reserve is diminished. And so we need to have everything else homeostatic and in the best the best form that we can possibly be in.
Right. Maintaining the best possible homeostasis.
Right.
Yeah.
Right. And we use Adderall all the time for patients with MS to help them focus, just like they had ADD, even if they weren't known to have ADD. It does help. You still need the sleep.
Yeah. Yeah, absolutely. Yeah, it does not help if I haven't taken care of the sleep.
Right.
Yeah, absolutely. That part about homeostasis feels so monumentally important to me, and it's hard because it's hard for a practitioner to help with that. And that's something we have to do on our own and with our families.
And it takes a lot of work.
Yeah.
Yeah.
I think for me, that's the biggest benefit that I have found from participating in a social support group is that just emotional grounding and stability with community, and also being able to say, oh my God, I did this crazy thing. I peed my pants last week 5 times. Or my brain is doing these weird things. Like, are these really my emotions? Am I really this depressed? Or is this stuff going on in my brain? Because it's hard, like maybe MS is causing depression, but it's easier to distance myself from those emotions associated with depression if I know that it's a symptom of this stuff going on in my brain, as opposed to something that is fundamentally coming from me and my experience of the world.
Right, and it's hard to tease that out, but MS, the structural things happening in your brain and inflammation can cause depression, can cause mood alteration and difficulty with sleep patterns and all the things that the brain regulates.
Yeah.
So the treatment of it is the same. You might need more exercise, more light. You might need an antidepressant. It's always important not to blame yourself.
Yeah, and it was a big when I first got diagnosed, I was opposed to pharmaceuticals of all kinds, and I thought I was just gonna do a bunch of research and read a bunch of books and create my own treatment plan and do it on my own, and that did not work out that well.
No, and there's a lot of people with that mindset, and it's a good mindset for most things in life, but for MS, we really still need to rely on drugs to get the immune system in check, and then add to those drugs all these other things,
the complementary
things, and the lifestyle adjustments, and the mental health adjustments, where you learn to deal with stress better.
Yeah,
it all makes a big difference in living your best life.
Yeah. Well, thank you. Thank you so much for your presentation and for sharing with us and for your flexibility. And we would absolutely love to schedule you for a successful in-person talk. And we will be in touch. Thank you so much.
Here. Bye-bye.